Good morning, everyone, and welcome. We look forward to having you in this exciting conversation today about the future of behavioral health. We're going to wait just a few minutes to allow everyone to be welcomed into the session, and we'll start here shortly. All right, thank you all for joining us for this conversation on the future of behavioral health. I'm going to pass it over to my colleague, Ashley, to kick us off for our meeting today.
Perfect. Thank you, Emily. Good morning, everyone, and good afternoon for those in Denmark. My name is Ashley McPhail, and I'm the Vice President of Strategy for the Texas Medical Center. And as part of this, I get to work with my colleagues across the TMC and with our colleagues in the Denmark Consulate General on these wonderful BioBridge programs. Just to kick us off, I want to give a little bit of background for those who are from Denmark on the Texas Medical Center, discuss a little bit of the BioBridge at a high level, and then we will start kicking off with why we're here on the future of behavioral health. So to start, the Texas Medical Center is the world's largest medical center. We have over 60 member institutions, and these are leading institutions in both clinical care and research. We see over 10 million patients a year and do over 2 billion in research funding. More research is done on our campus than anywhere else in the US combined. So it very much is sort of this juggernaut of clinical and research expertise all in one area. And as part of that, we do have a lot of collaboration that happens within innovation and clinical research. For instance, we have our TMCx, which is our accelerator program. This is where we bring up startup companies from around the world. Usually about a third of the companies are from outside of the US, but they come and they participate in both a medical device and a digital health accelerator program. We provide background information and do a boot camp to really dig in on all sorts of aspects from regulatory or things like that for companies to come and learn a little bit more. As part of that, we have had 5 Danish companies participate over the last few years. So it's just an area that we're continuing to build out and work together on. So what is a BioBridge, which brings us together today? This really is a time for us to explore life science collaborations. We've sort of broken it down to 2 areas: innovation, commercialization, and then research and education. This a little bit combines both of these together. So innovation and commercialization, how can we help companies get a little bit faster on track? So to bring their expertise in both startups and multi-industry companies together and learn a little bit more and have access to learn what is happening in both sides across the pond. To get a little bit more information, how can we help further that technology and growth with an emphasis on digital and medical device? And then, of course, research and education. How can we look at clinical research from both sides and really help to expand upon that? And a lot of that is knowledge transfer. So lessons learned, how can we take what each other is doing and capitalize off of that? And that is, of course, sort of a little bit of both for this group today is, what is that research and lessons learned in behavioral health that we are seeing both on the US and the Denmark side? And then, of course, how can we help for those startup companies who are joining us today? How can we help you sort of think about that and getting it to market? And what does that look like from where the future of behavioral health is heading? The Denmark and TMC BioBridge actually kicked off in March of 2019 when the Crown Princess Mary came to visit TMC as part of her trip to both Texas and South by Southwest, which is, again, right now, the virtual South by is happening due to COVID, obviously not being able to come together. Princess Mary is the patron of healthcare for Denmark. So she has a great interest in sort of pulling these together and working across in foreign countries to do these types of missions from that. And then in October of that year, so October of 2019, we actually did take a TMC delegation to Denmark to meet with the biobanks. We met with government, Ministry of Foreign Affairs, Ministry of Healthcare, as well as some innovation centers throughout Copenhagen and, of course, Aarhus. So that's been something that we are looking forward to doing again outside of COVID. This year has been a lot of webinars and just some one-on-one meetings just to really sort of catch up. We are hoping to further engage as COVID starts, loosening a bit. I want to give a very high level 2 or 3 bullet points on each of the country's healthcare systems. As everybody on this call knows, they are very different in sort of how we are set up, but we are looking for some of those commonalities and really where we can learn from each other. So I will give a very quick, for the US, we very much have a hybrid model of healthcare. We have a mix of public and private funding, with most people getting their insurance through the private market through their employer. That is by far the largest market in the US. We do have some public funding, mainly Medicare program, which is for those 65 plus or for those with disabilities, as well as Medicaid that helps low income families as well. So it's very much a mix of that. And then each hospital, we have both private and public hospitals, nonprofits, for-profit institutions that come together to sort of make up the caregiving aspect of the US government. On the other side, Denmark has the Ministry of Health, and from that they do have universal coverage. It is a bit decentralized, meaning that they have 5 regions, and those 5 regions provide the main aspect of care to each of the individuals. That's where their general practitioners are found, their hospitals, their psychiatric care are part of that. Then outside of the 5 regions, they do have 98 municipalities, and those really do a lot of the preventative care and health as well. And so their funding is both streamed from a regional level and then municipalities. I will say 98% of Danes go through their GP to then find a specialty. So in that regards, a lot of that is sort of similar to the US and how we find specialty and needing a referral to go see some of these individual doctors. The US is doing electronic medical records. However, Denmark has been doing it for a very long time. And there is one portal for all Danes to go to access their electronic medical records. That is something the US, of course, would strive to do, but we are not there yet. So those are just some very high level points. I could spend a lot of time and a whole nother session on this, but we wanted to very much jump into where we are today, which is to discuss the future of behavioral health. I will turn it over to my colleague, Christina, with the Denmark Consulate to give any other thoughts before we kick off the panel.
Thank you, Ashley. That was so well said. And even the whole Danish system, very well done. My name is Christina Clark, and I just want to introduce me real quick and not take up too much time. But basically, Denmark has missions, including the Consulate of Denmark in Houston, to facilitate this kind of relationship that we have with Texas Medical Center. It's twofold. So it relates both to helping Danish companies that either need to expand or want to gain access to the US market, is for us to help them with that access. But it's also for TMC and individual hospital stakeholders to reach out to us looking for said types of technologies that they're interested in. As Ashley said, Denmark has a long history as a life science country. A quarter of our export almost is related to life sciences. So from a government perspective, life science is important to us, and we would like to share and learn lessons learned between our 2 countries. With that, Emily, please take this off. Looking forward to it.
Thanks, Christina and Ashley. So good morning, everyone. We're delighted to have you with this conversation today. I'm just going to frame up a little bit of why we're all together and probably what brought you to this discussion as well. So, of course, behavioral health has been a big topic of conversation prior to the pandemic, but COVID-19 and also resulting downstream effects like unemployment and other areas of people's lives has caused this time to be a really key opportunity for us to have a discussion of how we can think about mental health care and really drive a different future. So right now we're looking at about 4 in 10 US Americans that are reporting anxiety or depression in this past year. It means that we have this opportunity to really rethink the world that we come back to and how we're opening up access to behavioral health care. With this conversation, we're going to be talking about a lot of different types of behavioral health care, not only in 2 different countries, but also with different patient populations who have different needs, stigmas, and desires to access this care. So I'm really looking forward to this discussion today and delighted to start introducing you to each of our panelists. So our first question is really going to be about how each of them are really thinking about the world of behavioral health. So Marie, I'd love you to kick us off and tell us more about where you sit in the Danish healthcare system.
Thank you, Emily. I will do my best. Well, hello everyone. Good morning, good afternoon. My name is Marie Paldam Folker. I'm Center Director for Center for Telepsychiatry in one region. And yes, Ashley, you did a marvelous job presenting our public healthcare system in Denmark. So I'm speaking from the point of view of telepsychiatry, or that is using technology to assist people with mental health care difficulties concerning prevention, treatment, support for recovery. So perhaps I can just very briefly just present my organization. Well, I'm part of Center for Telepsychiatry. We are an innovation and research center within one hospital. In Denmark, we have 5 mental health care hospitals. I'm based in one hospital in Odense, in the middle of Denmark. So unfortunately, you didn't visit us at your delegation visit, but next time do come and visit us in Odense. So as an organization, we strive to increase access to mental health care using technologies and to improve outcomes. That's basically what we do by designing and by delivering digital tools. So that will be my perspective in this debate.
Thanks, Marie. Vineet, we'd love to hear from you. Tell us more about yourself and your practice.
Sure. I'm Vineet John. I'm a geriatric psychiatrist at McGovern Medical School at UT. I'm also the director of the psychiatry residency program, so I could talk about the education part of it. But in the prospect of looking at what behavioral health and how it affects my population, especially when you're looking at technology, this becomes a big challenge because of a few issues. One is stigma continues to be a big problem, especially for older generation. As you could see, the younger generations feel pretty comfortable about talking about going to a therapist, but it's not the same for an older generation. And technology, and you'll hear more from my wonderful panelists about how powerful it is to change the whole infrastructure and the climate. But for my patients, technology is a big divide. They have significant problems navigating even a push button kind of a phenomenon, and difficult to get them online, even for a video conferencing. So this is a challenge we'll have to grapple with in geriatric psychiatry context. The other third problem I see in my patients is the concept of loneliness, especially which has been driven mostly by pandemic. And this has significant healthcare, I would say, impact in terms of worsening not only the mental health, it's also worse than the physical health as well. I'm looking forward to hearing the rest of the panelists. I'm glad to be here.
Thanks, Vineet. Always happy to have you. Michelle, would love to hear from you now.
Thanks, Emily. Thanks for having me today. So I'm Michelle Patrick-Quinn. I'm a psychologist by training, but I'm also director of research at the Menninger Clinic, which is an affiliate of Baylor College of Medicine. And I'm assistant professor in the Department of Psychiatry at Baylor as well, with Dr. Storch. And the Menninger Clinic, a little bit of background real briefly about Menninger. We are primarily inpatient hospital. We also have outpatient services, but we are a private psychiatric hospital. I will brag a tiny bit that we've been in the top 10 for the last 30 years for psychiatric hospitals. So I have to brag a little bit about us, but we're proud to be part of the Texas Medical Center too, as well as Baylor College of Medicine. And, you know, I think one of the really neat opportunities for us and to really think about is, and something I've been really interested in, our group here has been interested in, how we can improve inpatient psychiatric care. I think a lot of technology has really focused on outpatient kind of depression, anxiety, but I'm really interested, how can we innovate, change inpatient psychiatric care, use technology to assist in like stepping down from inpatient to, you know, an IOP or residential or partial hospitalization program. So I think there's just, we can't forget about inpatient too, kind of the serious comorbid psychiatric illness. And I've been reading more about that. There's been a lot of calls for technology to really start to address these issues as well. And so that's what I hope to kind of advocate for in this conversation today. I think there's tremendous opportunity also kind of from the more severe psychiatric illness as well. So thanks for having me.
Excellent. Thanks, Michelle. And Eric, we'll end with you.
All right. Well, thanks for having me. Echoing my colleagues on some of the innovations, there are a few other areas that we're certainly interested in. So my background is I'm a child and adult psychologist who specializes in obsessive compulsive disorder and related conditions, which includes anxiety, Tourette syndrome, and then working with kids with autism spectrum disorder who have comorbid psychiatric problems. So we've been interested in a few different areas in particular. So the telepsych stuff, we actually did an early study about 12 years ago where I had a lot more hair, but using telepsych in children with OCD, and it was fabulously successful. And then state lines kind of halted us right there, and reimbursement halted us. So we just paused it, even though it was good, and until a pandemic came about. But the other areas that we're thinking about are things like how do we take technology and help it kind of more accurately phenotype some of the problems at hand. So we have an NIH R01 it's about to get funded, that's looking at that technology. When you take your iPhone, it recognizes your face, but how do we take that and actually have it measure psychiatric constructs in a kind of a dimensional but more objective fashion than our standard, which is ask people like, how depressed are you, and a bunch of symptoms. So how can we look at that? How can we understand that in terms of interpersonal processes as well? In addition, beyond telepsych per se, we're thinking a lot about different service delivery models so that we're able to personalize treatment more effectively. And you really end up having kind of a continuum of care, where you may at the very top of it, for a very small proportion of people, like Michelle was saying, have inpatient for those really complex folks. Most folks don't need that. And maybe some start with an internet-based option. And then if they don't do well there, they have a kind of a in-person, or telehealth light option. If they don't do well, then they step up. And so we've had a series of NIH grants in children with PTSD where we've done exactly that component. And so we're working on that in children with autism, and as well as individuals with OCD as well, again, to just think about those various service delivery models on top of, switch to telehealth.
Excellent, thank you. So, I think we're going to really anchor a lot of this conversation around telehealth and how far it's come in the last year, despite a long history that Dr. Sorch mentioned, as well as Marie. So if we can also start the conversation with just framing what telehealth means to you. And Eric, I'll pass it back to you since we were just discussing that here.
What does telehealth mean to me? It does mean that I'm staring at myself for about 10 hours a day and marveling at how old I've become and that I really look like my father. Not that that's a bad thing, it's just a thing. But I mean, what it means, from the service delivery, it's all about the service delivery platform. And I think the advantages and disadvantages are both, warrant mention in terms of improved access, ease for the patient, reduced no-shows, and a lot of times improved clinical service, like in the case of OCD, where I want to be able to get into the home environment to do exposure therapy. On the flip side, there's a proportion of patients, whether they're older, as Dr. John had mentioned, or less technologically savvy, not necessarily older, or just it just doesn't work for whatever reasons. I think those are some of the challenges that can also come in, and I'm sure some of my colleagues can speak to those things. But I think that approach has really been appreciated by individuals that we've served here. And it has resulted in our kind of catchment area being Texas, because we don't have to meet them in person, you know, and they don't have to drive the infamous Houston traffic. So yeah, so that's what it means to me.
Excellent, thanks. And Marie, you think about telepsychiatry across a pretty broad area. So love to hear more from you just about how you're defining that and what that looks like for you all as well.
Well, I can of course agree with Eric on the definition: telehealth, telemental health, telepsychiatry, e-mental health. We have a lot of different concepts describing this service delivery model, or these different practices, because they are different practices and they employ different technologies, and I think that's quite important to stress, that different technologies mean different services. So definitely, to me, it's using digital tools to address the full mental health care continuum. So from early health promotion onto prevention, treatment, recovery, support for recovery. So the full spectrum can be enabled, strengthened by using technologies. I would also like to state very clearly that to me, telehealth is not a quick fix. Digital technology is not a quick fix. Technology enabled, supported mental health care can increase access to mental health care, can improve access to evidence-based mental health care, and that's what's the core issue of telehealth. So doing something differently. It's not an either or, it's a both. That's very, very important, and it's very, very important to address the potentials, the pitfalls, the pros and cons. Yeah.
Excellent. Thanks, Marie. I have a lot of follow-up questions, but we'll keep moving here. Beneath, what about you? How do you think about telemental health?
Like what my esteemed colleagues already talked about, to me, in the geriatric clinic, I would say video conferencing, teleconference is the easiest way. And during the pandemic, we were seamless in terms of transitioning into video conferencing. So for me, 90% of when you say telehealth, that's what I think about. But also with my connection to TMCx, I am also privy to some of these new innovative companies. And obviously the focus is also on digital mental health. And there's quite a lot of apps and technology which is emerging, which tries to capture the life of the patient beyond the clinic. So synchronous and asynchronous kind of monitoring and digital actigraphy, they say, and digital phenotyping, which was mentioned before. All those things are exciting possibilities of the future. I just want to piggyback on what Marie and steal a question from Emily. Is one of the pitfalls of this whole 10 hours of staring at our face or part of our face in this is some of these things are one, cause significant exhaustion, and so we are yet to figure out how to navigate that. So I'm looking forward to hearing from my Denmark colleagues. So they've quite it's a much into the future, so we can learn from them. Second, there's a lot of emotional distancing and a lot of dilution of nonverbal cues, which enhances our therapeutic rapport with the patient. And a lot of that is being taken away by the telemedicine format. So I'm very curious to hear about how to continue to humanize ourselves and continue to be as compassionate and therapeutically effective to our patients.
Thanks, Vineet. And Michelle, when I think about telemental health in an inpatient setting, we've talked before about that transition out and sort of making sure that the patients still receive support. But what other areas are really top of mind for you when you think about telemental health?
Yeah, so something, I mean, everybody's kind of addressed is really like the Zoom, right? That's the first thing I think of, even actually on the inpatient side, right? So during COVID, we've had a clinician Zooming in for IT and therapy sessions, right? Because we've really reduced the density of therapists. So it's been really helpful to keep, individual therapy going with their same therapist, and really useful. But there was some kind of figuring out the procedures for how to do that, who sets up the iPad, some of those kind of hardware, software training things. So I think there is opportunity to use that on the inpatient side and post-discharge, right? We know post-discharge from inpatient is one of the highest risk periods for suicide. Is there a way to use telehealth, telemental health to maintain that therapeutic relationship with people on their team that they really worked well with in order to reduce the risk post-discharge? I will say, I kind of have a more broad view of telehealth, telemental health. I think there's tremendous opportunity in integrating new hardware like actigraphy and wearables. And so we have more objective monitoring, not just, I've seen a lot of like subjective self-report, things like that. And I think Marie mentioned outcomes. I think we should think about how can we develop new outcome measures and the integration of new outcome measures that can really do some cool things, I think, and important things to track like concepts like sleep and psychophysiology that are really directly linked to psychological processes. So I think there's some neat kind of in-home stuff we can do as well.
Yeah, that's a great point, Michelle, thinking about telehealth, not only just as that Zoom interaction for that time that you're spending with your patients, but also incorporating wearables and remote monitoring and sleep assessment. And also, as Eric mentioned previously, seeing a patient in their own environment and how that can augment the care paradigm as well. So wanted to turn it over to Marie. So Denmark is really further along in this area than we are. How, besides that, virtual visit, are you thinking about incorporating other pieces of technology into the way that you're assessing and providing care?
Yeah. Well, obviously, using video consultations has been extremely important during the COVID pandemic. And of course, we've done that. It has been to us an extremely busy period because we are supporting the entire mental health hospitals in using these technologies, providing training, providing IT support, troubleshooting, everything to make the clinical visit frictionless as possible, and training the mental health care professionals in communicating as good as possible through the video medium. But of course, as Vinith is talking about asynchronous technologies, I think that's what we look forward to in the future. We are already using, we have an internet-based clinic at the Center for Telepsychiatry with national patient uptake. So I have like 8 psychologists sitting in our offices and serving patients all over the country using internet-based cognitive behavioral therapy. So this mode of telehealth, I think, is pointing very much towards the future. In Denmark, we use the concept of digital or stepped care. So these a service model where you can step up gradually to meet the patient's need. So from completely unguided information, psychoeducation, stepping up to unguided therapy programs, guided programs, and then blended care where you combine internet-based therapy with the physical visits in the clinic. I think that type of digital mental health is very much pointing towards the future, because you increase the capacity of the system using technologies in that way, asynchronous way, instead of, it's the one-to-many service model instead of the one-to-one. And this is very much where we are heading in Denmark.
Excellent. And Vinith, we've talked a lot about asynchronous models as well, but how they work into your existing workflows and also enhance your ability to connect with your patients and assess those outcomes. So can you talk a little bit more about what an ideal situation of, an asynchronous mixed with sort of the traditional model that you're looking for as you're evaluating and assessing technologies that might support your efforts to expand access to care in this way?
So Emily, you're pushing me to look into the future because that's not existing right now in Houston, I can tell you right now. So I'm very jealous of what Marie just said, and would not mind being part of Ashley's next team to BioBridge Denmark. But in my clinic, for example, well, I'll give you one a kind of vignette. So a patient presents with depression and gives you all the features of depression, and you're convinced it hits all the diagnostic criteria. You felt pretty comfortable, thinking about major depression as a diagnosis. You put them on an antidepressant. And traditionally what happens is then because you start a new medicine, you may tell them to come back in 2 weeks, but then since you're such a very busy clinician and the most popular one in Houston, I'm just kidding, your appointment is only happening in 6 weeks. And you don't even think about the fact that this is a patient, new medication. Had you had access to the asynchronous technology and you had access to what Michelle and Eric and Mary was talking about, their sleep patterns, their actigraphy, like how much they were moving, and how much text are they sending out to people, what they call digital exhausts. People are talking about that concept. You will see very soon, within a week of you starting your antidepressant, the patient is not sleeping, patient is moving about too much. There's a flurry of texts with certain grandiose overtones in the social media. And all these are fed to you through some kind of a mechanism, which makes you rethink that you probably missed the diagnosis. This is probably someone who was a latent bipolarity, and then they had actually now flipped into what we call a hypomanic state, and which will then make you aware of wanting to get them back. So this is kind of my prediction of what the future could look like, that you're not limited by that cross-sectional visits to the clinic, but somehow you're connected, and there's a kind of way to monitor how your patient is doing across, and not only as a way of monitoring, but also connect and intervene much early. That way you could avoid hospitalization. So that's my take of what asynchronous technology may look like, and they could come in many forms, through the phone, through the keystroke kind of mechanism, through wearables, as some of our colleagues have talked about.
Excellent. Michelle, do you want to add anything to that paradigm as well?
Yeah, it actually just really made me think that, right, that passive asynchronous technology, right? That's what Dr. John is really talking about, right? With wearables, and the technology behind the scenes is able to kind of provide insights, right, based on that data. And that's really powerful, especially if somebody doesn't have the insight to understand, right? I haven't slept in 3 days, they don't understand, that they're texting a whole bunch. And so instead you have kind of the technology informing the provider, right? There's a predictive kind of model behind the scenes that is saying, hey, alert, potential pattern for bipolar, like Dr. John said. But that's really passive, right? Because there's also like an active asynchronous technology where someone might engage with an app or something. But that's super dependent on the patient's ability to engage with the app, interest engaging with the app or the technology, motivation to do that. So I think the passive asynchronous is a really powerful tool, especially with people who may have more severe psychiatric illness.
Yes, Eric, anything else to add there?
Yeah, I agree. I think it does pose a couple challenges, though, that we need to be mindful of. So on the clinician level, we're already being asked to do a lot, and now we're being asked to do more. One of the differences, I suspect, with the U.S. system and, Scandinavia broadly, not just Denmark, but many other countries with centralized health systems is the way that we receive reimbursement. So that, the sort of the model, across the sea broadly is we want to take care of our patients, and if we can prevent problems, and that helps reduce our cost, and so on and so on. Here we still have a per unit of service model, so the clinicians are going to be tasked more with doing more, and I'm pretty confident that insurers are. I hope we have no one on this panel or in the audience, but are not going to be thrilled about saying, hey, read these data that were truly important, but do this and do it for free. So I think that's one potential challenge. And even if it comes within the auspice of a session time, then all of a sudden it starts begging the question of what's the trade-off? And so I think these are some challenges. Another area that's going to be a challenge are the ethical aspects that come into play. And this is, I think this is within psychiatry more broadly. I mean, what we're seeing is this renaissance of stimulation technologies that are exciting because now we can have procedure-based services. Now we can target areas of the brain more directly. But there's this question of, well, where does it end? If we can stimulate, areas of the brain involved with depression to reduce depression, well, can we stimulate areas of the brain that are involved in cognition to make, some of us smarter, maybe better dancers, which I think I could probably use myself, but like a whole host of different things that come in that we need to be just mindful of as it comes forward. And then the work-life balance is going to be this other piece that sort of links to the first. What we've all seen with the shift to telepsych is patients don't no-show and they don't cancel. And so I think a lot of us sort of relied on the cancellations to maybe catch up on notes or go to the bathroom. I mean, kind of a shocker. So honestly, the last year I've never worked harder in my life. And it's fulfilling and rewarding. But I think these are going to be some of the interesting challenges that we do have to grapple with as we move forward within the many positives. And again, as Michelle was saying, the wealth of data that we can collect to improve our understanding of people and their problems.
Many great points there, Eric, from how does this abundance of data actually get incorporated into clinical care and what impact does that have on the providers? Vineet, I know that burnout is a key area of interest for you, especially as you're thinking about training the next generation in the space. So how about you tell us a little bit more about your perspectives on how technology can augment the experience for the provider and hopefully reduce some of the burnout that we're seeing at a high level in the behavioral health space?
That's a great question, and I'm really enjoying this session, learning a lot. So when you look at the burnout data among physicians, one of the major variable is the electronic medical record. They call it death by clicks. So apparently, each click you add to your your daily ratio, it adds to your level of burnout. And they've done these amazing graphs about use of electronic medical records among a group of physicians. And it starts off at 7 a.m., peaks around 9 a.m. Right at this time, it's like peaking, and goes down a little bit during lunch hour, peaks again at 2 p.m., and then goes down around 7. And you might think that's it. But as Eric said about work-life balance, there is another uptick after putting the kids to sleep and after dinner. You go up to, there is another increase around 10 to 11 p.m. as well. So that's the kind of the regular use of EMR. One of the fantasies, and it is being thought about, is how you can integrate some of these asynchronous things, which Michelle talked about as well, into the EMR, which then makes you easy for you to integrate all this data coming in. It could be integrated into EMR. And right now, 60% of US healthcare is under one big EMR company called Epic. So that might be one of the ways we could think about to make our lives easier as well. But the other aspect of educating the current trainees. So one of the challenges we have here is that we are kind of following a very rigid curriculum. So some of the things Dr. Strauch talked about, like neurostimulation, it's a very hot topic, and we are happy to teach our residents all about a medial frontal forebrain bundle, median forebrain bundle, and other aspects, area 25 for stimulating for treatment of depression. But the thing is, in 5 years, there's going to be a huge increase in the number of digital therapeutics, which is going to flood the market, and our residents wouldn't know anything about it. So how can they become much more like discerning as the providers to sort of suggest something to their patients as well? So a huge gap exists right now in looking at what is appropriate to prescribe, what is an effective kind of intervention for our patients. And other than a few, I would say universities like Stanford, we don't have a curriculum in digital mental health right now in any of the residencies. So that's another big challenge for us.
Excellent. And Michelle, you talked earlier about sort of adjusting the outcomes, right? How are we measuring success of these new tools? Are we using the old frameworks and are we developing new ones? So in the context of looking at the future and making that accessible for providers to be able to see the results and really change the way that they're delivering practice, how do you see that coming about, right? Developing the protocols and strategies and then disseminating that information to the community. And what are some of the challenges that you see with that process?
Yeah, I think one of the biggest things actually has to do with the EHR, like what Vineet said, that like these outcome measures, whether it, even just subjective report, self-report, like our EHR can't visualize that data over time, right? Like with a line graph for a patient. So like, I think part of the burnout with the EHR is that the user experience is so poor, right? That the text is really small, the interface isn't clear, it's not logical the way that you like document, right? It's not like systematic. So like the UX of an EHR is not great and it isn't like ergonomical. It's not the way people work and think and the way clinicians work and think. So I think there's tremendous opportunity to change that interface and work on that. And then also to integrate outcomes better. So developing clear visualizations with severity scores, evidence-based measures, obviously, for subjective report, but then also the ability to interface with devices. That will be huge. And being able to import that data, maybe even in real time, right? Or, on a certain kind of cadence. Will be tremendous. But I mean, there's so many challenges with that, even just the interface of connecting a device to an EHR. But then also to be able to, there's signal processing issues. So I think part of kind of the training thing is we need engineers, computer scientists that work with psychologists, psychiatrists, right? We need people, very interdisciplinary groups working on, I think, this issue, especially with outcome, but I think also with the EHR, the interfaces, I won't say the one we use, but it's just, just in case they're on here. But, they're all the ones, I've used, even it doesn't matter what they are. It's hard to use. It's exhausting because it's so hard to use and it's not, it's not straightforward. So for clinicians, which becomes exhausting.
Right. Yeah. And through TMCx and our conversations with many of you here, we've certainly been having conversations about how can we alleviate that documentation burden? How can we hopefully alleviate some of the burnout that's associated with that, result for the providers, such that we're not having a lot of these providers leave the practice and even shorten further everyone's access to excellent mental health care. So we have been touching upon some of these difficulties, but would love to turn it back to Marie to share some of her lessons learned. So Denmark's ahead of us. You've implemented a lot of new things, but you've also had some challenges along the way and still have some existing hurdles with access and other things. So can you just share what that journey has been like for you all and what we can start to learn from how your transition has gone so far?
We definitely also have documentation burnout or burden in our system, but maybe not as bad as you do. In terms of lessons learned, I think where we are now, I think the corona pandemic or the public health crisis introduced by the coronavirus pandemic, it has in all of Denmark has ignited this rapid implementation of the digital tools, not just video consultations, but also apps, internet-based therapy services. They're cropping up all over the country, I think many people in Denmark and also internationally have hailed this as a big important change, long overdue. Some people have referred to it as a black swan of mental health, and this may be true, but given this speed, I think many changes have also been sporadic and been rushed. So reinforcing shortcomings of our current digital mental health tools. So this is where we are now. Actually, we are very much concerned about what you referred to in the beginning, Dr. John, this digital divide. So I think a lack of attention to health equity in development of digital mental health solutions is what we are concerned with. How can we address the digital divide? Because even though Danish citizens are among one of the most digitalized populations in the world, we still have troubles. We still have people not having access to technologies, not having mental health literacy to understand the health messages in the tools that we employ. So unexamined inequities in access and in implementation of digital mental health, as well as quality of care, is vital to address right now, so that we are not introducing or reinforcing digital inequities. So yes, we don't have the solution yet, but we're looking into it. And I think solutions require collaboration across government, across IT companies and mental health public providers. But we're beginning to address this issue. And I think that's actually an important learning from the pandemic, that we need to take this much more seriously than we've done before.
Eric, anything you'd like to add on the access conversation?
Yeah, I think there's also this tension between access and quality, and we have to be really, really mindful of that. So a lot of times what I'll hear is that we've made an intervention more portable, but it doesn't make it better. It just means people can access it more. And sometimes some of the digital interventions do exactly that. And they're claiming some significant effect, but they're definitely not working with the patients that I suspect most of us see. And so I think, again, there's just this tension there between that. At the end of the day, the individuals that this panel, kind of cuts their teeth on are really, really struggling. And so, which step models can often help those that are more mild. There are a lot of people who really require more intensive intervention, and we need to be thoughtful that is always going to be an option. And as we develop out these kind of lower levels of care, but at the same time, again, that quality thing is one of my foremost concerns at play. And then at the same time, the oversight. How do we keep having kind of I don't know, tailoring variables so we don't put someone in a low-level intervention when they're going to just fail that? How do we rescue them early on? If they're early in and it's just not working. So I think all these monitoring pieces will require additional effort. And then in the US, the challenge is going to be, where's it paid for? So lots and lots of positive things, but these other kind of factors that we have to make sure we don't lose sight of.
Yeah, absolutely. And Eric, can you elaborate a little bit more on how you think about assessing the quality of new entrants into the system? And you commented on a little bit earlier, but wanted to hear your thoughts there as well.
Yeah, I think it's with panels like this who have considerable expertise, and in this space who can be mindful of cultural factors as well, and going through an iterative process that has stakeholders engaged, and doesn't presume that you know the answers as you implement it, but that you learn along the way. Just from a cultural standpoint, I'll share a little story of I purchased a Volvo in Sweden about 15 years ago. And so I'm this New York kid, going over there. I'm super excited. I pick up my Volvo, and then I'm just like, hey, I want to go as fast as I can to get from point A to point B. And what was interesting is no one else was going as fast as they could. It was just me and my Volvo, which I don't know, it wasn't the coolest car maybe, but I was excited. And so when we sat down and had a drink with someone, I was kind of joking about this, and the response was, no, we want to be really thoughtful about gas consumption, because this was when it was $4 a gallon in the U.S. and even more across the pond. And it was more of this kind of cultural appreciation for the impact of an individual on society that I think was great. And so being mindful of the way that the U.S. views their healthcare system and how that can interface with engagement, adherence, and how that may differ as a function of other cultures. And then the myriad of factors that come in and moderate that and make it not a simplistic statement like I was kind of going after, have to be considered in terms of that whole implementation piece. But it is a process, and we need to have all the stakeholders at the table, providing their input, and making sure that we aren't sacrificing the quality or the robustness for factors like convenience, because as we all know, mental health problems aren't easy to treat. It's not like a broken leg where you splint it and in 6 weeks, you're good and you have an excuse for why you're slow now. And I think that's one of my biggest concerns as we move forward on things.
Excellent, thanks. And Michelle and Marie both discussed the full spectrum of care, right? Beyond the initial Zoom conversation. So I'd like to return to that conversation and hear, from each of you, how you're thinking about technology and the future of behavioral health, enabling you to access with good visibility and with not a lot of additional effort, a patient's journey through their entire mental health treatment paradigm, and how you think that the future could be enhanced by technology across the full spectrum of care. So Maria, I'll turn it back to you first.
Well, yes, this is an interesting topic, of course. I think that we have a lot to do concerning preventative, the use of technologies to prevent mental health technologies. So the bulk of tools are aimed at mild to moderate conditions, so not serious mental health illness, as you mentioned, Michelle, and not prevention. So the two kind of outer poles should be addressed in order to move forward. And I guess, it's just where you start, actually, and still also involving the kind of ecosystem, because I'm speaking from the point of view as a provider, a mental health public mental health care provider. We also need to engage the private companies in this innovation journey or endeavor, because they have very important tasks in this development. So addressing to them the needs, we need to begin to discuss more openly the needs in mental health care. So along with IT developers, forge strong collaborations where we have patients with the needs involved in the development of digital tools. I think involving patients and carers much more ambitiously will address a lot of the challenges that we have addressed already, that we've talked about here in the panel. Also the question about digital inequity. We have to have the users on board because they know what's difficult in navigating the existing healthcare system.
I just want to jump to Vinny quickly on the topic of prevention or assessment. So in the US, it seems a bigger, steeper hurdle to figure out how to get prevention and assessment paid for in some cases. But Vinny, especially on the topics of cognitive decline or loneliness, as you mentioned earlier, how are you thinking about how those get incorporated into a new standard of care in geriatric mental health?
Right. So I think the cognitive issue is an important issue as people are living longer and they tend to have cognitive decline as they age, and age is the biggest risk factor for development of serious cognitive problems like dementia. And right now, pandemic is a very critical time. And I have to tell you, from a geriatric psychiatrist point of view, I haven't done a proper cognitive assessment on a patient because a lot of this is in a pencil and paper kind of tests, and you have the patient sitting across to you and you're sharing with them the test and they're doing it in front of you. You can gauge their difficulty, you quickly get the results. So this is a great opportunity to look at if this is a situation whether you have any kind of other measures of cognitive capacity which could be done remotely. This is a great opportunity for us to sort of engage with those kind of technology to assess where our patients are. So one of the things I want to go further on what Christoph was saying is that part of the challenge with all these new technologies is that we have no way of assessing what is rigorous in its methodology and effectiveness, so on and so forth. So to sort of figure out what is a good technology to adopt as part of your clinical practice, the same kind of rigor and scientific kind of scrutiny you deploy for a medication, you may have to have clinical trials which then meet the criteria. Otherwise, we may fall for someone with the biggest hype. So I'm just saying is that, maybe that's another way to sort of create some kind of a discernment among providers about what technology to use. But that, again, requires investment and generosity of clinical sites and some kind of an arrangement between the, startup company, which may not have the funds like huge pharmaceutical giants, which are currently producing, pharmacological agents. So something to think about as well. Regarding the assessment part of it, again, we are very much in the infancy. I can tell you that there are a lot of companies interested in adopting well-established scales like PHQ-9, which gives you a quick run through of depression. But in some discussions, we end up figuring out, as Dr. Storch talked about, the legal aspect. So if there is a one concerning kind of an entry which is being, entered by the patient about suicidality, who's ultimately responsible? Who is really monitoring at 2 a.m. when the patient decides to take that survey, and who's responsible? So these are the kind of sticking points which are still not resolved yet. So there is a lot more work to be done, but we are still caught up in the, I think, enthusiasm for innovation, but then translating that into solid clinical kind of, I would say, practical and best practice is going to be difficult for us.
Maria, it looks like you might have something to add there as well.
I was just thinking you should come and visit our clinic in Denmark, because, well, of course, we treat in our internet-based therapy service, we treat patients with mild to moderate anxiety and depression, so not severe anxiety or depression, mild to moderate, but we do the PHQ-9 through an online screening, and then we do the present state examination, so the PSE, during a video assessment, so a video-based interview where the psychologist assess the patient's symptoms. And then, of course, we use a treatment platform, an online treatment platform with weekly scores, so PHQ-9, suicidal ideation, with an alert system, and of course heavy security measures. So if we have a patient with elevated scores of suicidal ideation, we have an alert going to the psychologist so we can react. So it's possible to do it. Yeah, but of course, mild to moderate, not severe.
Emily, I just want to kind of reiterate, I think everyone said a really important point that I think subjective experience of the technology is important, culture, everything, but that kind of the biggest thing, like innovation needs to be grounded in science for mental health, right? That at the core, there has to be evidence-based intervention, assessment. A lot of times I see some startup companies and they tell an anecdotal story about what motivated them, and they have designed their product based on their individual personal experience, which I don't want to take anything away from that. That's incredibly important, incredibly motivating. But in order to reduce some of these inequities, ensure maximal outcomes, like innovation has got to be grounded in psychological science, psychiatric science, and that has to be the core, I think. And I think I'm hearing that. Don't want to speak for everybody, but I think I'm hearing that too.
Absolutely, certainly shared by all of the panels today, the evidence-based outcomes that you're measuring and reporting on, as well as the implementation into a clinical environment, workflow, physician's behavior, right? Our earlier conversation about the documentation burden and the need for asynchronous communication to then filter into a real kind of care paradigm is ultra important and top of mind as we are all evaluating new innovations that could be supportive in this case. Dr. Storch, did you have anything else to add around those areas?
No, I mean, panel said it well. I echo the need for robust evidence-based interventions, and that we have clear justification for using what we use. I think in psychiatry sometimes that's kind of left out. But if we want to be considered an equal, quote unquote, discipline of medicine, this is integral to have as part of that. And it'll vary, and there'll be many things that work, but we need to be able to again show why it works, and have an estimate of how strong or robust the treatment might be.
Excellent. So, oh yeah, Marie, go ahead.
Yeah, can I just add? Of course, I agree that of course we need evidence-based, robust solutions, but that's not enough. That's my experience coming out of the COVID pandemic. We also need private companies and their abilities in designing, engaging IT tools that are easy to use, easy to understand. When we started out in the beginning of the pandemic, we used our top secure, terrible video solution that patients they couldn't use it. Our clinicians, they couldn't use it in the numbers that were expected due to closing down face-to-face services. So we changed our video solutions overnight, and that made a huge difference in terms of uptake to patients and clinicians. So my point is just that we need both sides. Yeah.
Excellent. So of course, with innovation, it's always about these details. So when we think about, how does it get rigorously evaluated? How does it get implemented into the workflow? How does the patient enjoy their experience? And of course, how do they access it? So let's assume in 5 to 10 years in the future that we've all met different companies and innovators and other colleagues who've developed these tools that are easy for patients and providers to use, that have a great ability to expand access and to really rigorously have evidence-based measures that they're improving care. So assuming all of those things are taken care of, what are you looking forward to seeing in the next 5 to 10 years as you future cast about what behavioral health care and your own practices could look like? Dr. Storch.
Yeah, all right. So one would be more, let's start assessment. So more precise assessment. We mentioned the PHQ-9, we can do better, and so we need to leverage technology in a realistic fashion that can be taken up by clinicians without bankrupting them or burning them out. And I think, that's some of the work, we're doing, that, Michelle's doing, and so many others, but has clear applicability. And the technology is there. It's just a matter of the engineers and the clinicians getting together, having a drink, and then, letting the pickles stick on the wall. So I think that's one of them. And what that will result in is kind of capturing illness before it becomes blown up. You think about this in terms of, one of this grant that we're about to get is, it's all about how do we understand when someone has autism, even earlier. How do we know when someone's depressed by virtue of their facial features? And there's applications of this in things like Parkinson's, where you can hop online in a forum like this, it videotapes you, and then looks at your facial features to start detecting, potential signs and signals. So I think that's one area. Now, the other important part of that is that it's going to reduce error variance when we look at our intervention models, which are now all about PHQ. And you know what? I didn't sleep well last night because I was super nervous. Emily, I thought the questions would be, I thought you'd throw me under the bus a couple of times. So I was, but like maybe that impacts my presentation today. And so my PHQ is a little more negative. I mean, the point is that we'll be more precise in our assessment, which will allow us to capture things early, intervene earlier as appropriate, and have a kind of less error-laden assessments. I think a second thing that's going to happen is frankly, I do think the quality of intervention will continue to improve. One of the biggest issues that I believe, from my perspective, is that we're training a host of mental health providers in the US, but many of them are not being trained in the things that we know work. So my kind of area is OCD. Houston is blessed with a number of great OCD providers, but you know what, that's a fraction of a percent of them who really know how to treat it effectively. But the average person doesn't know that. They see that they have X insurance and Y person's on there, and so they call them, and Y person says, yeah, come on in. And half the time they refer them out, but then they can't get in to see anyone. So I think we're going to see this kind of uplifting of the quality of care, in part because insurers are going to be more savvy about what works and what doesn't work. So I think that will be another medium. I think we'll also see a greater mix of in-person intervention, but also telepsych. I think that genie is out of the bag, and it ain't going to go back. And that should cut across the various continuums of care. And my hope is that some of the lower intensity interventions, for example, researchers in Sweden have done incredible work with internet-based CBT for various problems. That we start seeing some level of reimbursement for that, because it's not just here's the program, go off, but it is less intensive. And so a couple of the models that we're doing with one of my close partners, Sophie Schneider, are really geared towards how do we have lower intensity interventions, and for kids with autism and anxiety or OCD, where we teach the parents how to do this, and it requires fewer sessions, but we're able to improve access, by virtue of fewer sessions. So I think those are a few changes that will take place. As well as, I guess I should say, I think there's going to be more and more neuromodulation that's going on, which there's going to be a tricky balance between the sexiness of neuromod versus the efficacy. So if you think of, transcranial magnetic stimulation, it's really exciting to see how that works. But you do have to beg the question of, is it working better than seeing an expert psychotherapist or psychiatrist for 30 times in 6 weeks? Like, that's a lot of time. I mean, I would think if I saw Dr. John 30 times, like I'm cured of everything at that point. These are real questions that we have to think about in terms of the relative benefit of new interventions. And is it just that it's new and exciting versus it's advancing our field in a meaningful way, which is meaningful and important too. So I think that's another part that will be interesting to see in 10 years. By the way, from the beach of some Central American country, at that point, I'm just pointing out. I'll be viewing it from there. So.
I love it. Dr. Patrick Quinn, anything else that you'd like to add on your vision of the future of behavioral health from your perspective in the next 5 to 10 years?
Yeah, that was all great stuff. You know, the only thing that I would really add would be, my hope is that mental health technology, you can utilize all this data, right, in science and develop elegant solutions that maintain that therapeutic alliance and connection, and can kind of actually augment that, as well as a bit stay hidden, right? So like I'm thinking really on the inpatient side, how do we innovate inpatient care? And we can use technology from a whole different areas, different lights for sleeping, or different safety protocols, and different ways to create maybe like coping skills with new technologies on the inpatient side. Maybe when you go in seclusion, you actually have like a virtual reality thing that I don't know, right? How can we make technology a part of our world, but not our entire world, right? How can it really augment what we do? And because, you know, I think especially on the inpatient side, one of those biggest things is, you know, patients need to feel safe and secure, and they can feel very agitated and traumatized by other facilities, you know, all sorts of things. So how do we kind of, and technology can be a big part of the problem too, right? Like they have been texting all sorts of people or on social media. And so how do we utilize technology in a way that is supportive of our treatment, right? But it's not everything, right? It's not in your face. I think one of the best examples, I was in a hotel and went into the bathroom and there was a mirror. And then all of a sudden I was like, oh, there's a remote in here. And the TV was in the mirror. And I was like, wow, that is amazing, right? The TV is not on the wall. And I was like, that was just such a neat kind of example of technology being there, being present, but it's and available to you if you need access to it, but it's not monopolizing your focus, I guess. So my dream is that we develop elegant solutions that are science-based, but that aren't, they aren't, you know, increasing our kind of need and sometimes addiction for technology too.
Yeah, I aspire to have the kind of balance in life in general that you described, Michelle, as well. Dr. John, what about you? Any other thoughts that you'd like to add around the future of behavioral health in the next 5 to 10 years?
I think I'm coming back to the basics, which is basically access. I mean, even now, significant amount of people who are really ill don't have any access to care. So any way of harnessing technology to, you know, improve access, even as a kind of a digital triage nurse for mental health, you know, someone to sort of say, this is not the mild situation, you need to go to the emergency room, so on and so forth. So that's one of my hope that we could see in the next a few years. The other important aspect is to, I would say, and I think it's gradually changing, and technology has a role to play, the stigma towards mental illness. There was a study in which they surveyed people, asking them, who do you feel most comfortable with? A kind of a AI-based virtual therapist, which is completely cut from any kind of human intervention, or this virtual therapist as controlled by experts in psychology, and a significant majority would rather be comfortable with this sentient being, which has no human control, which means that people are still worried about a judgmental response from their fellow human being, which is very strange and counterintuitive to what I would have thought, because I would have thought people would be blown away by the compassion of therapists, but people rather trust an AI system than an actual human being. So maybe this may be another way to decrease the stigma towards mental illness. There's a lot more trust in a way people can be honest, and that somehow we could harvest this and give them the right kind of education. So access and stigma are two things I would be like hopeful would have changed with technology.
Big focus areas and challenges for us in the next 5 to 10 years, for me, for sure. Marie, what about you? looking at the future, what does it look like?
Well, I hope sincerely for a future where we develop digital technologies with service users instead of developing them for users, so that we take advantage of the full resources, the full scope of resources of people with the mental health problems and their relatives, their friends and families, that we enable this scope of resources to be part of the process of developing and implementing new technologies, and especially as Vinith says, that people with mental health difficulties can be part of this endeavor to end stigma and to use technologies to take control of their situation along with mental health care providers, because they are of course completely necessary. But the technologies can help them in this journey. That would be my super dream.
I love it. Are there any parting words that you'd like to share, any of the panelists, with our attendees today, many of whom are themselves developing mental health solutions or practicing in their own case? What are your last thoughts? Eric, go ahead.
The field has moved forward so profoundly and meaningfully in the last 20 years, and it's exciting to see what will what will continue to happen. But the questions we are addressing when I first started my career are dramatically different, and I have to think that we'll see exponential development. With many thanks for the partnerships, for those on this call.
Excellent, Michelle.
Yeah, I would just say, if you're innovating this, thank you too, and awesome. Keep up the great work. I mean, I am just so impressed with people's dedication and interest, wanting to collaborate and think about these issues. I think we can't thank you enough. I think in the mental health community for the computer scientists who are now interested in these questions, and the engineers, and a lot of people who maybe haven't gotten training in mental health now, these creative, really kind of innovative, impressive minds working on these issues. And so I would just say, please keep working on it. Reach out to those of us who are interested in it too, in the mental health community. And we appreciate you joining us, I think, and developing. Thanks.
Marie?
Yes, I can just add, yes, we need a lot of different players because we have so much work to do. So yeah, keep it coming.
And Vinith, anything else you'd like to add or share?
No, I think my wonderful panelists said it all. And again, I echo Michelle's commendation to the developers and the entrepreneurs in the audience, because they're trying to capture the elusive human experience and in the best way possible. And in that, there could be secrets of lots of aspirations towards wellness as well.
Excellent. Well, it was such a delight to have all four of our panelists with us today. Before we close out, Ashley McPhail is going to share a few more notes, and we're grateful for all of you for joining. Ashley.
Thank you, everyone. This was a great conversation. I just have two quick notes that I wanted to give just as we wrap up. First, as you just all heard from the panelists, about thank you to the startup companies and the designers that are looking to innovate this. Along that line, TMCx, our accelerator program, our current applications are open until April 2nd. And one of the focuses of this next round will be behavioral health. So we do encourage everybody to apply. If you need more information, please reach out to us. We're happy to give you that. But that's a great next step to also sort of get to work with these wonderful panelists that you have on, who very much are interested in seeing the future of this and how we can work in partnership to develop. And then the other thing I will say is, as part of these BioBridges, we are now starting to do the future of webinars that are different topics every other month. And Denmark has a special place in our heart, but we do also have 2 other BioBridges, one with the UK and one with Australia. And so these will pull in experts from across the world with our BioBridge partners and those at TMC. So the next one will be in May, and it's going to be the future of the patient journey. So really thinking of, and that has changed dramatically as well as sort of what we've talked about today, but with COVID and some of those interactions. So that will be a panel that will be coming out. So we encourage everyone to attend that as well. And we'll be sending out more information of that closer to time. So with that, I will pass it back to Emily just to give closing thoughts, but thank you all for joining us and thank you to the panelists.
Thanks, Ashley. It was such a pleasure to be with each of you today. Thank you all for joining us. We're just thrilled to have such great colleagues and collaborators, both here and in other countries, that can collaborate with us and support the future of what healthcare can look like. And so we at TMC are delighted to facilitate these type of conversations, as well as dive deep into individual conversations about how some of the innovators that we're working with are directly tackling these issues and building new solutions together with some of the great panelists that you've seen here today, as well as many others across our TMC Innovation and TMC networks. Thank you again all very much for joining us. It was such a pleasure to have this conversation with you today.
Thank you, Emily.
Thank you. Yeah.
Have a great day.
Thanks.